Okay, good morning. I want to introduce Gabe because I know all the good stories. So let's just ask Gabe some questions. Where did you do your training?
So I trained in Cleveland, Ohio, internal medicine residency in Cleveland, infectious disease fellowship training at UCSD.
And then how did you get into the research that you do?
Through you. So I was interested in HIV research in some way, shape, or form, and there was opportunities in Davies' lab studying HIV superinfection and how it relates to the neutralizing antibody response in the host. And I worked in the lab for 7 years.
Okay, I can't take blame or credit, I don't think, but and then what do you like to do for fun?
Snowboard, movies. All right. So thanks everyone for coming. Today I'm going to talk about mHealth for HIV prevention. Basically going to be a bit of a review of the current state of affairs, talk about the different avenues that are going on, talk a little bit about the future of it, and let's get into it. No disclosures. So the first part of the talk, we're talking about opportunities for mHealth research for HIV prevention, specifically focusing on PrEP. Then applied examples. Then I'll go into some of the limitations that are present with mHealth research, and then I'll end a little bit with future directions. So why is this important? Well, there are still HIV diagnoses. There's still new infections. This is the HIV surveillance, the newest CDC HIV surveillance report from 2018. So in 2017, 40,000 new cases still. And as you can see, predominantly there's a disproportionate burden on Black MSM and as well as Hispanic MSM, Hispanic Latino. Interestingly, the incidence has kind of plateaued, decreased by some measures, but despite this, among Hispanic Latino MSM, the rate of incidence has increased since 2012 by 12%. New HIV diagnosis, this is the same, but broken down by age, basically just to show that the new infections are happening most frequently among younger folks. 20, this is the 25 to 34 bar. 13 to 24 is the second highest. And we have PrEP now, pre-exposure prophylaxis. We know that it works, but yet there's still a difficult, slow uptake, especially in populations that need it the most. So this was presented by Don Smith at Croy last year, from the CDC, and you can see that. So this was prescription data analysis. So this is in retail pharmacies, and over a course span of a year, and you see that there were 44% of people who could benefit from PrEP are African American, and that's approximately 500,000 people. But there were only 7,000 that actually were prescribed PrEP or had. This is by prescription fills, so that's only 1%. And among Latino, Hispanic, the rate was 3%. So it's if there's going to be a chance of significantly curbing the epidemic, the PrEP needs to be increased significantly more in these populations that need it the most. There's also this article just came out earlier this year. Erin Seidler. By the way, I borrowed heavily from Erin's slides for this presentation. This is a display of PrEP deserts in the U.S. So here, this is census tracts, and the little blue dots, which are kind of hard to see, are PrEP providers in the U.S. And basically, so what they considered PrEP, this is a heat map. The redder the color, the longer the distance to a PrEP provider. And so they considered anything 30 minutes or more drive to a PrEP provider was considered a PrEP desert. So basically anything yellow and beyond. And so basically, what they found was that 1 in 8 PrEP eligible MSM, men who have sex with men, lived in one of these PrEP deserts. And a substantial minority actually lived in one of these greater than 120-minute PrEP deserts, mostly in the south. And but you can see I know it's kind of hard to see, but even here in San Diego County, there's a spot of red. And there's still a problem in the PrEP continuum, right? So this also came out earlier this year, also from the Emory Group. They looked at pharmacy fill records of 7,000 individuals who initiated PrEP in 2015, and this is persistence over 2 years, and it was not good. Persistence was 56%. So this is broken down uh, by age here, but basically the persistence was 56% in year one, 63% in year two, and it was 41% taken altogether from day zero to initiation to year two. And as you can see, and this will become a common trend, is that individuals that persisted with PrEP tended to be older. You can see that as the bars go down, the younger they get. So the problem is that the success of PrEP uptake um, across the continuum is challenged by these individual, structural, and societal barriers. And we're going to need comprehensive evidence-based interventions to optimize PrEP. And we need to make prevention work to maximize the potential for digital tools to address the gaps in the cascade. So mHealth can help. mHealth in its many forms can impact the barriers such as distance, such as stigma, and it approaches mHealth approaches can leverage digital tools and devices that are already present everywhere, such as cell phones. So this is from the Pew Research Center. Um, this is the rate of cell phone ownership in the blue and the smartphone ownership in the green. And basically, 96% of adults in the US have a cell phone, and 100% of young adults have a cell phone. And I think 80, some high 80s% own a smartphone. And, this is from 35% is when they started tracking this in 2011, 2012. So, it's exploded, um, as we all know. So exposure youth are avid consumers of social media. So 90% use social platforms, and most 71% use the platforms more than once. The three main ones being Snapchat, YouTube, and Instagram. And adults spend 2.5 to 5 hours daily on smartphones. Don't need to tell you all. I'm sure you already know. So intervention exposure versus cost. So one challenge in behavioral research has been to try when you deploy an intervention, it actually, the ones that are evidence based are the ones that require the most amount of time, the most amount of staff time. So this is a table of cost of staff time versus intervention exposure, and the most staff time also requires the most amount of money. So with mHealth and technological tools, there can be automation of some of these things to try and alleviate some of the costs. The CDC actually has an evidence-based HIV prevention tool, this every dose, every day toolkit, which is designed to help providers support medication adherence among people living with HIV. And it interestingly has a mobile app component, but also consumer handouts, so it's the mixing of traditional tools as well as digital tools as well. uh, the nice thing about mHealth too is that it allows for adaptation to changing culture. So as I'm sure you all know, also um, the ways of communication and the etiquette of communication is changing. When do you call? When do you text? When do you post online? When do you talk face to face? So there's even like the rules for digital communication. I guess some of these I wasn't even aware of. If you have time to post on Snapchat, you have time to respond to text messages, whatever. So with the changing norms, you can adapt prevention messages and prevention strategies using these platforms. So this I got from Lisa Hightow Weedman she gave an excellent presentation at CROI this year, 2019. And basically, a fair amount of formative studies have been done, and they have identified a set of comparable preferences, and this is across multiple settings in the US and globally as well. So, preferences for comprehensive mHealth interventions, and there are a few features that are consistently mentioned, and these include, sorry, maybe a little hard to read, but facilitating connections to peers and providers. So users do enjoy that peer connection as well as a connection to the provider. Inclusion of discrete reminders for HIV prevention, care-related activities. So discrete reminders, not actually saying HIV test, but having an emoji or something instead. Provision of comprehensive, holistic, and accurate information. Games, rewards, incentive for usage. This is especially true for young users, and careful attention to privacy and confidentiality. So there's always going to be attrition, and in many of the mHealth intervention trials, a substantial proportion of users dropped out because they got sick of using the app or the website. So it's going to be important to incorporate youth um, by finding out ways to do so. So, incorporating youth focused engagement strategies can support acceptability, usability, and adherence. And this means tailoring the intervention to users, again, fostering social peer support, inclusion of game based elements, provision of self monitoring and feedback. This has also been shown to be quite helpful, and push factors such as reminders and notifications. So now let's talk about some of the concrete examples that are out there. So in general, this is not a comprehensive list, but it touches on the main modalities that are out there in terms of tech. Um, so this includes short message service. So this is probably the most common because it's the most applicable. I mean, it's not just smartphones. You can also use the basic phone that can only handle texting. You can still do texting. Web-based plus or minus mobile optimization. So a lot of apps are mobile apps, but some of them do have a web-based component. Smartphone apps, social networking, media-based. You see some of them here. Telehealth and video counseling, and we'll talk about that later, especially as it relates to prep care. A lot of that is already kind of moving forward. Virtual reality or artificial intelligence, and then wearable devices and electronic adherence monitors. And I'll mention some of that as well. So as far as the prep continuum, the first part, I guess, is the prep engagement and uptake. So right now, there's a study that is currently enrolling at UCSF. This is called the FAST study, Hyman Scott. And the purpose is to understand facilitators and barriers to mHealth use among young Black MSM. And this is the app. It's called Sex Pro, and it integrates a personalized HIV risk assessment with home HIV and STI testing options and prep facilitation. So and ultimately it'll enroll 80 Black young MSM, which is a good number. Um, and then we have the problem with prep adherence, right? Once you start, then to actually continue to take it. So this is a study from the UCSF group. Here they did the mixed methods evaluation of their intervention called iText, which is weekly bidirectional texting versus email support messages to encourage prep adherence. This is a convenience sample from the iPrec study, 56 MSM, predominantly or 25% less than 30 years old, 13% Black, 11% Latino, 12-week pilot study, and actually, it's kind of hard to read. But basically, it consisted of an automated bank of answers to standard questions. And then, if there was a problem, if the patient reported that they were having a problem or an issue, then a provider would actually call them within 24 hours. And the pre-post intervention analysis, and this is using clinic-based pill counts, by the way, showed a 50% reduction in missed doses, Younger participants and men of color were more likely to report that they would use eye text if it was available. And participants commented that they felt supported and encouraged that someone was always there, quote unquote. Even though this was an automated machine that was giving the responses, and they knew that, it's still they still felt the support. Study staff reported that intervention was feasible to administer and could be readily incorporated into clinical flow. This is our group, actually. David Moore, Joe Blumenthal, Sheldon Morris, many others. So individualized texting for adherence building. This was 398 MSM and transgender women, randomized 1-to-1 to ITAB versus standard of care. And basically what they saw was that at week 48, ITAB was superior to standard of care for near perfect adherence. So these are the graphs. This is week 12. So the black is the ITAB, the gray is the standard of care, week 12, and this is at week 48. And week 48, 51% versus 37.4%. And that was statistically significant. And they also observed that older individuals tended to be more adherent, similar to what was observed earlier. Um, PrepMate is another similar youth-tailored bidirectional text messaging intervention. This is from, I believe, the UNC group, and participants who received PrepMate were more likely to attend study visits, 86% versus 71% in the standard of care, and have dry blood spots, TF, tenofovir levels consistent with more than 4 doses per week. So this is, again, I borrowed from Lisa's talk. Uh, Meta-analyses, integrative, and systematic reviews provide confirmation of there's a moderate short-term effect of SMS messaging. So SMS messaging is productive and it's giving an effect, but it's not uh, long-lasting. Sustained effects have been less robust, particularly among youth. So studies are more likely to report larger effects when texting texts were not sent daily, when they supported bidirectional communication, and when they included personalized content. And we'll talk a little bit more about the personalized content. This is another app that was developed by the UNC group. This is called P3, Prepared, Protected, and Empowered. Comprehensive mobile app developed to support PrEP adherence through gamification, social support, and self-monitoring. It's got an in-app portal for deliverance of adherence counseling. I believe it's um, integrated next step counseling for PrEP adherence. And the pilot results showed improvements in self-reported adherence and increases in tenofovir levels and increased self-efficacy and reduction in stigma-related adherence barriers. And moving now to PrEP adherence, PrEP uptake, PrEP adherence, and long-term PrEP persistence. And this is where telehealth can really start to help. So this study, this is Jeff Klausner, UCLA, but this is actually UCS. The study was recruited from San Francisco Bay Area. So it was called PrepTech. So this included 25 young MSM, and they received telemedicine visits, home delivery of Truvada, and STI testing kits. So this is a cohort that is similar to that target that I mentioned early in the earlier statistics. So young and predominantly 84% young MSM of color, 40% Hispanic Latino, 32% Asian Pacific Islander, 8% Black. At least 75% felt that PrepTech was confidential, fast, convenient, and easy to use. And less than 15% personally experienced PrEP stigma during the study. And what this basically was, this is a web-based intervention. So you actually log into a website, and there you go through the process, the registration, the um, uh, risk stratification, and everything is through the website. And then they mail it to you. And it got good feedback. So these are some of the quotes from the participants. So PrepTech has allowed me to have access to PrEP in a way that would be otherwise difficult, stigmatizing, and expensive, offers a confidential feeling that the daily reminders are definitely helpful, keeping on track with the medication. And another participant said that being open about accessing PrEP is why I enjoy PrEP tech. No ambiguity or concern as to whether I'd be approved so long as diagnostics came back compatible. First time I talked to regular doc about the issue, she basically shamed me and tried to scare me into celibacy. So um, yeah, so Iowa TellaPrep, this is another TellaPrep intervention. This was deployed in Iowa. This is a collaboration between the University of Iowa and the Iowa Department of Public Health. And um, this really was designed because Iowa is a largely rural state, and so they were trying to get at that the PrEP desert issue that I mentioned earlier. So 186 referrals to the program, 127, 68% completed the initial video visits, uh, median age 32, 91% MSM. And most clients with video visits started PrEP, and the retention in TellaPrep at 6 months was 61%. So maybe a little bit better to some of the numbers I mentioned earlier, but still not great. Most individuals were able to complete their lab testing without problems. This was a pilot study, or I guess a pilot experience that this is Joann Steckler in Seattle, Washington. So from July 16 to March 17, 10 out of 48 initial PrEP visits at the Gay Men's Health Clinic were conducted through video conferencing, and no significant difference in PrEP prescription in the first follow-up visit or in PrEP adherence at 1 month. However, for the 3 month visit, only 2 out of the 10 telehealth participants attended the 3 month visit compared to 20 of the 23 standard participants. Interestingly, those two had missed significant amounts of doses in the previous month. So unclear why the poor follow up there, but obviously there were some issues. Three telehealth participants completed the survey. All reported that it was very acceptable to see the PrEP doctor using video conferencing, and they would be very or somewhat likely to recommend telemedicine. So these are some of the experiences, and the VA system also has already a history of using telemedicine, and I think telemedicine for PrEP may be deploying soon. I'm not sure. Yeah.
Thanks. In terms of that poor follow-up, do you know if they're looking into why so many people missed the 3 month visit? Because that then basically doesn't really work if no one's coming and only 3 people completed a survey.
Yeah. I Yeah, so this is their. I think she is still collecting data, and she's so there are probably going to be more reports about this, but yeah, doesn't bode well. Plush Care. This is a commercially available app actually that this is designed by techs and physicians. This is you schedule the appointment on your phone, speak with the doctor, and they prescribe they send the prescription to your local pharmacy. Uh, and in fact, this is the app that California has a PrEP assistance program, and it has contracted with this app to be able to do PrEP app processing, which is fantastic, and this bodes well for future telehealth approaches. This is another application. This is a research application from Emory, again, Erin Seidler, a full telemedicine PrEP app. It's called ePrep, designed for rural young MSM. It's got all the basic features: telemedicine, text messaging, automated reminders, and progress tracking. It's got this integrated interface based on familiar platforms, and it's right now being rolled out in a randomized control trial in the Adolescents Trial Network (ATN). A sizable sample too. This is another modality, also Emory, also Erin Seidler, Prep at Home. This is a testing kit that is sent to your home. It has all the STI testing components already inside, all the forms that you need. You fill it out, you send it in, and you get your prep. And this is I think it's still enrolling. I think the study is still continuing for another year or so. So we'll get to hear more about it. Um, so this is now our work, or my work here that I've been doing more recently, is is specifically leverage telehealth for Latino MSM. So there are specific barriers to PrEP uptake among Latino MSM, and these include stigma, and there's different kinds of stigma. There's PrEP-related stigma of the quote-unquote Truvada whore, or the fact that the individual might be more risk taking more sexual risks, HIV-related stigma, and homophobia as well. So this, a lot of Black and Latino Black and Latino MSM report that they would not want to go to a PrEP provider because of the association, because these are typically housed in HIV-related clinics or in gay LGBT centers. Cost, or insurance costs, concerns about efficacy and side effects, medical mistrust. So medical mistrust, and different, as I said earlier, different populations have different issues. So among the Black population, this is actually more of an issue, medical mistrust, because of the years of institutionalized racism. Language barriers is more of an issue with Spanish monolingual, with Hispanic monolingual Spanish speakers. Lack of provider access. We talked about the PrEP deserts. Actually, in studies, they have found that counties that have the least amount of PrEP providers also have the greatest amounts of minorities, Black and Hispanic. And provider unwillingness to prescribe PrEP. Yes, that does happen. And lack of awareness. So to avoid exacerbating these disparities, um, we need the tailoring and the customization. So we are right now applying for grant funding for a formative study. The ultimate intervention will be basically using Epic MyChart, which is the uh, the main EMR system that UCSD uses, Epic, as well as um, uh, I think the majority of academic or tertiary medical centers, it has this standalone app component called MyChart that incorporates telehealth visits as well. This would be administered by a Spanish bilingual provider, uh, but before we get to that point, we first need to collect formative data, and this would include online surveys, focus groups, and in-depth interviews to inform the design. So the sample will be 100% Latino MSM. This would be the development of a mock intervention that then would be pilot tested, and then there would be feedback, iterative refinement, and then feedback again, iterative refinement, and that way produce a product that has the user tailoring in mind. There would be four subgroups specifically that we would look at. It include monolingual Spanish speakers, non-gay identified MSM, young Latino MSM ages 18 to 24, and rural MSM. And here's a schematic of what it would look like, basically just phone to phone. And then as far as PrEP adherence, so mentioned before, wearables and monitors. So this is actually our group here, one of our groups here. This is Sarah Brown with the edible ingestion sensor, the digital health feedback system. So Proteus is this company that has produced this edible ingestion sensor, external wearable patch, and paired mobile device. Uh, I actually had never seen one of these live. I saw a patient hospitalized at UCSD here in the hospital, and he happened to be part of the study, and I didn't know what the patch was, and I was like, "What are you wearing on your abdomen?" And he explained to me that it was part of the study. I'm like, "Oh, okay." Um, it detects medication ingestions and physiological measures simultaneously in near real time. So, and this particular study will enroll 30 female participants, initiating or continuing PrEP using DHFS, and assess longitudinal patterns of PrEP adherence in women within low socioeconomic and health disparity racial ethnic communities. I believe the follow-up, is Amanda here? I believe the follow-up is 12 weeks, or Connie. Um, So limitations of mHealth research. So there are a couple of limitations. So there's a timeline mismatch. So, you know, what is the typical timeline of research or, traditional biomedical research is seed funding, 1.5 years, pilot testing, 2.5 years, and clinical trial or the randomized clinical trial operation, 5 years. So that's 9.5 years. And yet, as we know, the pace of tech changes all the time. People may remember the Palm OS when the iPhone was launched, and just to give you an impression, and the when wearables became, it- just to give you an idea. So this is a nursing group looking at behavior and dietary changes, and this is for use on a PDA, and these were published in 2012, 2011, 2011, and by then PDAs were no longer used. So there's also development conundrums. So the technology intervention development is expensive. So to develop a mobile app can be hundreds of thousands of dollars. There's information asymmetry. So there's the coders. Typically, health practitioners are not coders. That includes MDs, epidemiologists, behavioralists. They don't know much about code. And then there's the actual programming risks. So it would be good for it to be future proof, and that means that it is built in such a way that it doesn't become outmoded in a short span of time, that it be updatable, so that it is in modules, so that if you change an aspect of it in the future, the whole thing doesn't break. That it be transferable, so that another coder can pick up what another coder wrote earlier, so that it not be too stylized, or that it is well annotated, that it has the proper architecture, and that it is stable, and that it is secure. And this is important with privacy and confidentiality. In that last note, so this is an article that came out, I think, last year, looking at reported data breaches of protected health information from 2013 to 2017, patient records affected. And just wanted to point out here, so these are the numbers. I don't know if you can see, but the numbers here are 102 million, 12 million. So these are vast amounts of records that can potentially be affected with a single security breach. So sustainability is an important problem as well. So health apps developed by researchers may never be translated into a production model. A lot of the apps that I've mentioned so far are research apps that actually have not. These are things that can't be downloaded for public use. Um, in fact, when Erin presented this slide, he had actually done a very brief NIH review using the reporter tool, and found that I think there was like 40 grants that had developed for all these HIV apps that had been funded. None of them had translated into an app that you could just Google, that you could download. So need to define a business public health model, app platforms, updates once research is completed, responsible party to manage the app's ongoing resource needs, and a sustainable resource stream as well. So some potential solutions to this for the timeline mismatch. So use theory where relevant. So theory-based hypotheses can provide interpretable results in the wake of substantial technology change. And how this will look exactly is difficult to know, but definitely sticking with one app or one platform or one tool is probably, and then testing that in a randomized trial is probably not the way to go. Closely document intervention and future reproduction in different media. And this is where collecting paradata that I'll talk about later becomes important. So looking at how people move through the app, recording that to understand what about it worked. I, in the future, begin conceptualizing solutions with societal and healthcare technology changes, and adapt as soon as possible. And important to begin with the concept in mind from the beginning, of the intervention that you're designing. So Internal development team for mHealth intervention creation. Okay, yeah. So this is development security conundrums. Um, so yes, for interventions like this, it would be great to have an actual team that that can keep the development going at the same time. So there's increased oversight, but at the same time, there's a cost uh, effect. There's a need. They need sufficient size to attain the scope of the work team with academic partners and local programs with coding. Develop the oversight capacity with an expert in coding and architecture, and include university partners that may provide oversight for security purposes, such as our own. And universities have their own IT systems that can help with this as well. Sustainability. So some potential solutions. Early discussions with program and policy leaders to explore program possibilities. And in a lot of the and the HIV epidemic and these implementation funding announcements that I have seen recently, the emphasis is on the implementation sciences, on partnering with community partners, which is going to be important for some of these things to move forward. Incorporate concerns into research question, partner to address key issues. Um, Consider business avenues. Existing businesses may be a quality avenue to attain scale, high relevancy in era of biomedical prep with more potential for profit. And I'll talk a little bit later about partnering with pharmacies. Consider involvement of local health authorities, PrEP app, public health departments, as we saw earlier. And finally, future directions. So this is technology within the Adolescent Trials Network, ATN. It's called iTech, one of 3 funded U19s comprising the Adolescent Trials Network. This is like a super project that supports over 10 technology-focused studies addressing full prevention and care continuum for youth. The majority of studies are engaging young MSM and trans youth, with the total number of planned participants in iTech being more than 3,000. So more to come. This actually, what I was talking about earlier, business partnership for sustainability, pharmacy-led models. This is Susan Buckbinder in San Francisco. So this PrEP 3D digital diary and delivery system. This is a pharmacy-led model of PrEP delivery. The online pharmacist provides PrEP prescription, orders, tracks, lab monitoring through collaborative practice agreement, medication delivery through the courier, and it provides online tools as well. So a pill sex diary, bidirectional text messaging, and support adherence and persistence. So this is a platform that is trying to be a little bit more comprehensive and integrate multiple components. Um, Community pharmacies may provide useful setting for high poverty, minority concentrated neighborhood PrEP provision. This is important. And this is what the future might look like as well. Avatars, agents, and chatbots. So this was, I believe this is from UNC, called My Personal Health Guide. This is a theory-based, mobile, delivered, embodied conversational agent intervention to improve adherence to ART in Black MSM. And this is kind of what the interface looks like. So far, the pilot study has demonstrated acceptability and preliminary efficacy in improving adherence, and trials to be underway. And then down below here, this is another intervention. This one is called Tough Talks, and I want to say this is also from UNC, but I can't remember exactly. But this is developed actually for disclosing your HIV status. So this is for young MSM living with HIV to learn about HIV disclosure, to practice it in a safe space. And the pilot study has demonstrated high acceptability, and randomized control trial is underway. And this is harkens back to what I mentioned earlier, paradata and precision health. So this is going to be important. This is data on where and how users access and move through the intervention. So not just capturing the actual data and the data they are capturing in the surveys, but actually capturing data about how people use it, how they interacted with the intervention. It helps understand which components led to the behavior change and who responded to the intervention and who did not respond to the intervention. Effective engagement is required for behavior change support. It's likely to differ across users and contexts, as I mentioned earlier, depending on the group you're working with. So tailoring is needed, and it can only be determined by analyzing complex patterns of relationships between usage, user experiences, and outcomes. So this will involve significant amount of work and big data analysis. And that's basically coming to the end of my talk here. Take-home points, mHealth will likely be a component of future PrEP scale-up. mHealth has the potential to be leveraged to address existing health disparities, and novel strategies are needed to address the limitations of mHealth programs. And with that, thank all the people on the slide and the funders. Thank you. Questions, discussion? Neve.
Thank you, Gabe. I have a quick question about whether you've come across any apps for on-demand PrEP and how to use it. And I'm just curious your feelings on that. If you, because patients are asking about it. We had someone we saw from Belgium a couple of weeks ago, and he had a whole app and dosing recommendations for it and everything, and it was being recommended in where he was, the PrEP clinic he was followed at in Belgium. So I'm just curious, is it like off the table? We have a lot of patients asking about it, and just curious if you have an opinion on it.
Yeah, and feel free, anybody, to pipe in, Jill. But I don't, so far, most of the apps, the ones that I'm aware of are not looking at that, but there is a lot of demand for that, actually, and hence the on-demand PrEP, and that's why the adherence of at least 4 days in a week is important for these studies. So to my knowledge, in the major groups that are looking at apps like this, it's not something that they're looking at, but it's something that I want to say people are very much aware of.
I would just add, I mean, it is approved that way in Europe. That is why, I mean, it's been studied there, and that is how it's recommended to a lot of people. So I'm not surprised. We do not have such recommendations in the United States. I highly doubt there will be NIH sponsored or apps that make that recommendation. And when FTAF comes out in the next month, so many of the concerns of accumulation of toxicity is really going to be gone. That being said, I think still people there's some people who would prefer to take fewer drugs, and it's something that's absolutely discussed, I would say, in our PrEP clinic and with others about using that strategy. They have to be very clear about what that strategy looks like. But I would have a hard time imagining there'll be, research-approved apps that look like that.
Yeah, that's true. I guess most of what I have been looking at is, NIH-sponsored research groups, and so maybe that's why I didn't come across that. Now, some of the apps are being like the P3 Empowered app that's also going to be deployed in Africa as well. So some of these apps will be deployed everywhere. There was another question.
Are there any mHealth apps for pharmacies? And the reason I'm bringing it up is because there's a bill that's going back to the, I think the Senate, that's going to authorize pharmacists to, after taking a course, to prescribe PrEP and PEP without seeing a doctor. And I was wondering whether anything is being done to facilitate education or follow-up as for pharmacists, etc.
Yeah. So some of the efforts that I described in the talk do touch on that a little bit. In Seattle, Washington, actually the Iowa PrEP program is pharmacy led, and the Susan Buckbinder's program is also pharmacy led. this is pharmacy led in conjunction with team. So that typically includes physicians and other folks. But yeah, several of them are pharmacy led. Yeah, several of these approaches are. Yes. Hi.
So one of the slides that you had that I found really interesting had to do with the uptake and initial acceptance of mHealth and the people's persistence in using it. About a decade ago, when I was working at Family Health Centers, I was involved in the original pilot of the Text for Baby initiative that's since rolled out nationwide. And it struck me that the initial uptake, as well as the continuing interest in using the intervention, seems to drop much faster here than it did for pregnant women or women who had recently given birth. And it strikes me it might be worth looking, and I'm wondering whether anyone ever has looked at what the factors are involved here, whether it's purely this is all about me versus me and a baby, or whether there's a men-women thing going on here, or whether it's that a baby is a known thing, whereas getting HIV isn't, and whether there's learning that could inform the messaging. So like the Text for Baby messaging often involved not just the individual, but the community. By vaccinating your baby, you are helping all babies. But when your friends do it, they're helping your baby. Are there things that could be incorporated in this that sort of build that sense of community, which might play really well with Latino populations? I'm just wondering what's going on there. Has anyone ever looked at that?
Yeah, I'm not familiar with this particular text program that you talked about, but yes, definitely when it comes to these approaches, the emphasis is heavy on trying to tailor and incorporate I talked about the peer support that that is utilized in some of these apps, especially when it comes to testing or HIV testing, about getting young people engaged and involved in kind of a communal peer support type of setting.
Thanks, Gabe. Just one, I guess, comment is what we are having trouble with in our PrEP clinic is reaching patients after they leave the clinic, because so many of our young patients don't answer their phone or don't want to answer their phone, and don't use email much for quick communication. And I think these interventions are great, but we can't even text message patients from the EMR or in a secure way to communicate with them. And so, and we've been handing out surveys to patients about how they prefer communication, and almost 100% circle text message. And so I just think that even something as simple as trying to drive our IT team to create a secure way just to communicate via text message might help with PrEP adherence and things like that.
Yeah, that's a very interesting point, Lucas. That I'm aware of, I don't think anybody has really looked at the actual texting, the regular texting that all our phones come with, because of the HIPAA, because of the privacy and confidentiality issue. Almost all of these is around the building of the app. It's around the building of, and even our proposal is going to be using Epic Mitra. Everything's inside that environment, and I don't know. It's going to require some big ideas to work around that. But I think you're right. Definitely for young MSM, texting, emojis, games, that's kind of the way gamification is the way to go. There was another question.
Hey, so I had a question about, in terms of like the barriers that you presented, like the time lapse and clinicians not being coders. I was wondering, in terms of trying to overcome those barriers, if any of these projects or even your project has considered trying to partner or reach out to tech companies, not necessarily like Google or Apple. That'd be awesome. It's a grand idea. And I think that would be awesome for such a grand project too, but just any kind of tech company to help you really speed up the process of making such a difficult thing that a clinician really doesn't know too much about.
Oh yeah, several of these efforts do. Yeah, it's this entire field is really all about partnerships, especially because clinicians, are not programmers, they're not coders, and so it does require even, for example, the wearable Dr. Brown study is a partnership with an already existing company, Proteus. So yes, that would be key.
Well, I liked your discussion of the timeline mismatch, but there's also a conceptualization mismatch in dealing with these tech companies. Their interest is to get an app or a product out there as fast as they can and to make money off of it. And they don't have much interest in actually testing it in an academic setting. So it's us driving the academic testing and applicability of this technology in a healthcare setting. Most of the companies just think they can create an app, put it out there, and people will use it, and don't really have any desire to support academic efforts to apply it in a more rigorous setting and to understand how people use it, why they use it, when they use it, and what are the factors that contribute to it. And I think the other point in terms of the mismatch is certainly with the electronic medical record. The HIPAA compliance and all of the constraints that are put on our being able to use the electronic medical record for any kind of communication with the patient makes it absolutely impossible to overcome some of the obstacles you've talked about in terms of barriers to people regularly using these apps and communicating through them. So I think there's a lot of work to be done on both sides of that equation, and just having technology partners doesn't necessarily mean that they will have the same concept we have about how to use these.
Yes, definitely. It will require thinking outside the box, because these are issues that have no easy solutions. Yes.
So just to piggy on that, I wonder if it wouldn't be in Gilead's best interest to find a great app that people could voluntarily use, so therefore they're volunteering their vulnerability of their privacy. Yeah, no, that'd be great. Yeah, because I mean, for Gilead's, okay, because I mean, it's, the apps, they want to make money, right? I mean, Gilead wants to make money. The apps, right, but the app is the advertising. It's the vehicle to keep people on it and keep refilling those prescriptions. And so maybe we need to change our mindset, with these apps is, are they getting used or not? And maybe think about the apps the way the rest of the world does.
I was just going to ask if you know of anyone who's working on integrating these sorts of mechanisms into already well-utilized applications. So I think of downloading an app versus using something on Facebook or Instagram or something like that. Having a separate app to me is much more noticeable, and it's a larger interruption to my routine, more so than getting text messages or getting a notification on Facebook. And of course, it would take that kind of volunteering to have that vulnerability. And obviously, there are many other issues associated with large social networking apps and data and all of that. But I was just curious if you knew of anyone exploring those integrations.
Yeah. So most of the stuff that I presented is the development of, and these are the attempts of comprehensive platforms like ePrep, like P3, but into like an already existing app, not to my knowledge.
Yeah, I think part of the problem is that apps like Instagram and Facebook have their own proprietary technology, and trying to partner them with another technology company that has their proprietary technology is not an easy thing to do. But there are attempts just to utilize things like Facebook and Instagram as part of a messaging system in clinical trials, but actually integrating different technologies into Facebook and Instagram, I think, has been a much harder sell to companies on both sides. So
we did try that for instance, scheduling for Good to Go. And most of those apps are all about sharing. They're not about privacy. So there's no HIPAA compliance on Instagram. So we were not able to use it.
I think your data breach slide is sort of, to me, that is why so much of this will never happen, is even if people voluntarily say, yeah, that's okay for me to do, if it's coming from an academic institution that has any kind of liability, there's no way that, you know, someone's data could be so easily accessed. I think that sort of squashes so much of this within, you know, even outside of, within, you know, just regular medical care. And I think that's the biggest problem. I think we should wrap up. Anyway, yeah, sorry.
Thank you, everyone.
Thanks.